Once again, welcome back. Moving forward with the next session for the day. It's Journey to Insight, a healthcare case study, ladies and gentlemen. Uh, the speaker will talk in depth on how patient centricity is one of the most critical needs in today's connected healthcare ecosystem and how machine learning algorithms help to bring the connectivity between data and insights, which helps to drive actions. Extracting right information or patterns from data, the key to the success for capturing insights on past, present, and future. The current talk will uncover data science aspects of patient's journey to drive patient centricity across payer, provider, and pharma companies, ladies and gentlemen. The speaker holds 12 years of experience in data science, having expertise in practice areas such as patient analytics and customer-centric marketing across various domains like healthcare, manufacturing, pharmaceuticals, and e-commerce. He has also co-founded Warwick Analytics UK based on his PhD thesis. He has published a number of articles in the research areas on operational research and management, soft computing tools, and advanced algorithms in leading journals such as IEEE Trans, EJAR, and IJPR, among others. He has also co-authored books such as Algorithms and Data Structures Using R and R Deep Learning Cookbook. He is the data science manager at ZS Associates, ladies and gentlemen. Please welcome with a huge round of applause, Dr. Prakash.
Thank you. Hello, can you hear me? Well, okay. All right. So today we are going to cover one of the topic which is very commonly fall into sequence mining. So basically how the journey can be extracted. So the talks but basically divided into two different segments. The first we are going to talk about what the patient centricity or the journey is going to look like. And then we will go into dig down into some of the case studies or the applications which how we can use that data. So for the first part, I think I have Shankar with me. Shankar is a partner at ZS Associates. He leads the advanced data science practice in India. He holds around 15 plus experience in healthcare analytics industry. He holds PhD from IIT Madras and PhD from Purdue University and bachelor's from IIT Madras. So please welcome Shankar. I think he is going to take the first part and then we can continue with the case studies.
Thanks, Prakash.
Thank you, Shankar.
Thank you. Sorry, we're just going to do a little bit of a tag team, a little change in the program. But just wanted to take 5 minutes to kind of set the motivation and the context for why patient centricity, and then Prakash will kind of walk you through some of the interesting things we're doing in this space. Okay, so, but show of hands, how many people have some experience in the healthcare or life science spectrum? Okay, there's a couple of folks. Okay, all right. So maybe we'll start a little bit more at the foundations, and so you guys at least have a little sense of what we're talking about in the industry context before we dive deeper. So let's go to the next slide. Okay, thank you. So of course, customer centricity is all there is, right? So if you think about Amazon, one of the prime leading principles that Jeff Bezos kind of indoctrinates in his employees is customer centricity, right? So in fact, at the Amazon meetings, apparently they have an empty chair, and that signifies the customer. So while we're talking, let's make sure that we are keeping the customer at the center of our business thinking, okay? And Zappos does not have a marketing budget, okay? They say if we do it right with the customer, our products will sell, right? So this notion of customer centricity is something that's kind of pervading the business world more and more. And of course, we at ZS, we have a lot of experience working with life science clients. Historically, the life science clients have been, like when you think about their sales and marketing divisions, the KPIs that they'll measure themselves by will be like product sales, are generating more prescriptions. But even there's been a move towards customer centricity, okay? And so GSK GlaxoSmithKline is one of the pharma large manufacturers. They started incentivizing their sales representatives on customer satisfaction. So it seems like something that other industries do a lot of, but this is a big move, right? Moving from thinking about your product volume and the business that you're generating to how do you effectively satisfy your customers. So there's a move towards this. So I'll ask one more question. So in the life science or spectrum, if you're a pharma manufacturer, who are your customers? HCPs. Okay, yes. Sorry? Doctors. Doctors or healthcare providers. That's a more technical term, but so doctors. Who else? Chemists. Okay. Sorry? Insurers. Okay. But who actually consumes your product? Patients. Right? So interesting. But yeah, it's a kind of an interesting space because the person who makes the decision, typically who's a doctor, doesn't pay for the product. The person who pays for the product is the insurer, but they are not the ones who are consuming the product. So it's kind of very interesting dynamic of network of customers that you need to think about. And until like about 5-6 years back, I would say the bulk of the life science industry's focus was on the doctor. Okay, all their business decisions, the sales and marketing activities were tied towards influencing the doctor who was making the decision. Because just like this is again, I'm speaking a bit more in the US and global context, but the doctor was prime because doctor was God, right? Whatever the doctor said, the patients did, and largely the insurance companies would pay for those products. But that has evolved quite considerably, right? So when now we go to our doctor's office, we have already searched Google, we have looked at Wikipedia, we have looked up all our symptoms, so we go with 10 pages of information and we start questioning the doctor, right? So we as a patient are much more informed. So now the doctor has to be ready to answer those questions and queries that come from the patient. So that's one key change that has happened with the advent of information. Second is, especially given the high healthcare costs in the US, now there's a lot more focus on cost. And so the payers are passing on more of the risk to the patients. So there's some notion called high deductible plans. Okay, so you have to pay a lot more out of pocket before the insurer starts paying. So now the patient, earlier if they took a $1,000 medication over the course of a year, they had to pay out maybe $40 from their pocket. But now it's becoming where $200, $300 are coming out of the patient's pocket. So earlier they would be okay with getting a branded product because the insurer was paying. But now they are asking more questions on, is this really what I need? Can we use this other product? Can I not take drugs? Can I start with something else, right? So that patient's wallet is getting hit a lot more. And so consequently the patient is even more aware of what treatment choices are being given to them. So the fact that the patient is more informed, the patient gets a bigger hit on the wallet. And the third thing that is happening is there's a lot more focus on something called outcomes. Right? Earlier, life science industry would be focused on, let's make sure this patient starts on our brand, we'll keep them on our brand. But now, more and more focus on, is this brand working? Okay? Is this really, like say if I'm suffering from diabetes and start taking a pill, there's more focus on, is this reducing the HbA1c levels? Is my blood sugar under control? Right? So in fact, the government in general is moving towards measuring the providers and the payers on the quality of the outcomes they're delivering to the patient, not just the fact that they provided a service. So that the fact that it's hitting the wallet of the patient, now the entire ecosystem is worrying about the outcomes of the patient. Are they really getting better? And fundamentally because the patient is becoming more informed, now the patient is coming at the center of life science industry. So that's why we're talking about patient centricity. Right? Earlier it used to be about the doctor, but now it's much more becoming about the patient. Okay? So when we talk about patient centricity, it's rather interesting. So there is a spectrum of things that happen along the patient's journey. Okay? So I'll probably start with something. Let's say you have a product that's already in the market, and you worry about something like patient activation. Right? Activation meaning, has it been diagnosed with a disease? Right? And then it comes to now what treatment choice are you going to make? Do they have proper access to care? Right? Are they getting the right degree of reimbursement support to get paid for it? And then ongoing, are they staying on the medication and is their disease under control? And then ultimately, is it resulting in a better outcome for the patient or the experience is good? Right? So there's a whole host of things you need to worry about. Now, what is the role that data and analytics play in this space, right? And so Prakash is going to talk about some of the things we are doing in this kind of along the life cycle of the patient and their journey. How can we help our life science clients to really help their end customers, the patients? So that's what I'll invite Prakash to say that. Oh, sorry. There was one more thing. Oh, sorry. Can we do that? So, sorry, there's one more thing. Is like there's this whole journey, and then there's a lot of different interventions that are happening. So, there's clinical decision support systems that are in place to help in the earlier part of the life cycle. There are adherence programs that come to keep a patient on therapy. So, there's several interventions that a life science company plans. So, our essential hope is how do we use data and analytics to make these business decisions more effective. Okay.
Thanks, Shankar. Thanks for setting up the context. All right. So as Shankar mentioned, the patient actually go through a lot of different cycles, and there are a lot of data which has been collected about the patient. Either it is a claim level, pharmacy level, doctor level, and using that particular information, actually you can do a lot of different actions or can be decided, or basically you can optimize the process, how to reach out the patient to achieve that centricity or optimize your service. Just to give in some of the examples from mostly focused over the pharma industry, but it can be actually can be applied to the payer or any other industry. Is one of is when the patient is actually taking a drug, right? Especially for a chronic diseases, if they are, for example, they have a diabetes or they are under rheumatoid arthritis. It's a long-term chronic disease, and they have to be on a pill continuously. Can we detect whether they are going to adhere to the process, when they are going to drop off from the process? What is driving that drop-off? Once you know the driver, potentially you can intervene into the process. So that's from the patient journey, from their therapy perspective. But when the patient is within the network, they are moving from doctor to doctor. So that's where how they're moving within the process, how the referral program is working. Once you know the cohort, which cohort of the doctor referring to each other, how their path is actually designed, you can actually potentially use the information to determine who are the key opinion leader within the doctor, which can be used for understanding who is driving the whole thing. So for example, I think one of the challenges you can face is a specialist doctor write just one prescription and then refer it to the HCP, then HCP start writing most of them. But if you look into the claims data, you will find that the most of the dominance at the HCP level rather than a specialist. But the specialist is the key opinion leader in this subject area, how to drive or discover those kind of information. Then the third potentially could be the patient journey itself. So especially in some of the chronic diseases, there could be how they are moving from one line of therapy to the other line of therapy. Especially if you look from the cancer or in an oncology space, there could be a different therapy process before the onset of the cancer, and there is a different therapy which need to be found out. Within the therapy, there could be multiple option or alternative which they can use. So what actually driving them to move within this journey? Can we detect or infer that information? That the case study 1, 2, 3 are more from the inferential perspective, but actually they can be easily converted into a predictive case. So for example, can I predict what event is going to happen with the patient? For example, if I know the cancer onset is going to happen, can I predict when it's going to happen? So there could be time versus event philosophy which can be actually happen for some of the case. So just to cover one of the use cases, maybe I will cover two different. One is more from a retrospective perspective, which is more an inferential exercise. Other is more prospective, where we'll try to predict the event. So just to give you an example from the patient adherence analysis, I think how do you define? I think it's one of the common. If I go to a cross industry, I think churn is one of the standard problem. If my customer is coming to me, can I predict when they are going to churn? Is a similar analogy in the healthcare industry. If a patient is taking a therapy or a drug, can I predict when they are going to become a non-compliant or going to become a drop-off? In this, there could be two situations. One is if they're taking a medication, they are continuously taking a medication, they are a more compliant patient. But the second situation could be I am intermittently taking a medication. I am skipping some of the doses. So I'm basically I'm a non-compliant patient, but I'm still taking the medication. Third scenario will be they completely stop taking it. So they become a drop-off kind of scenario. So one of the things is what actually driving that drop-off. For some of the industry, I think predicting the churn, the definition of churn is very, very easy because you know whether they are on the telecom or they are not on the telecom. But in this scenario, how you define the churn itself? Because there could be scenario when it could be non-compliant with a very long gap, right? So the marker itself become a lot of hypothesis in this information, plus how you collect the data from a multiple different sources, which actually need to be used and concatenated, because there is a claims information which is involved, speciality which they are using, EHR data which they are using. So all this information need to be collated to basically figure out when they are on the therapy itself. And once you figure out the adherence, the next would be the driver. What is actually driving the system? Whether the driver is stable over time or it's actually changing, how it's changing for a segment, because some patient may have just dropped immediately, some patient have dropped off after some time. So how you basically extract those information. So the way we actually formulate is the first part, because this is going to be inferential exercise, we have to understand what is actually driving the whole thing, or what the hypothesis. For example, is the switch is driving. So basically, if I'm actually taking insurance from a payer, is the rejection which is actually driving the drop off, or if some sort of conversion is driving from a retail to mail order kind of thing. So basically, it's more around how you're receiving the pills. Or the demographic factor associated with the patient is actually driving the failure. So there could be a lot of, you need to define the hypothesis which could lead to this drop-off, followed by you basically create those markers within the data, because we need to extract that information by integrating multiple data sources, and then basically extract those features, followed by the second step is basically segmenting the patient journey. Once you actually have those patient journey so whether they are compliant versus, so basically if the long-term journey, basically on the time when they are being compliant versus non-compliant, how their philosophy is changing. So one of the thing is potentially the people who are early dropping off may have a different driver versus the people who drop off in the mid versus people who drop off in the last phase of their journey, right? So the second part is basically how you basically homogenize and extract the homogeneous segment, and then basically run a classification system to figure out what are the most important variable over time. So for the longitudinal, basically you do a longitudinal clustering using MaxDiff to determine which patient are very, very similar. Then followed by any classification modeling exercise. So basically this could be at a different level, 1-to-1 or 1-to-many kind of philosophy, where you just try to figure out whether patient versus dropper versus compliant, how they are moving across. Followed by the feature importance. Basically, if you use the relative feature importance, they will actually tell you which feature is actually driving which part of the model. And the third is, although the feature is important, how much patient they are actually affecting. So that's the prevalence part of it. So how much prevalent that feature is within the data. So that's the third dimension. So we actually use the random forest for the classification perspective feature importance, followed by all the longitudinal segmentation at a different segment level. So what we see that there are a group of patients who early drop versus then there are some group of patients who are initially they become a non-compliant, and then the later part of their journey they actually dropped off, followed by there are patients who are completely compliant at the end of the day. And we try to see the driver, how they are actually changing over time in terms of how these drivers keep moving. Some of the drivers, so the driver which is coming out of critically is not only payer related, it comes out to be payer versus physician profile, patient profile versus your pharmacy profile. So one of the things which is coming out to be critical related to the switches or the rejections. So if the patient actually tend to switch the payer, I think that's due to rejection, they actually tends to drop off from the therapy. The copay card utilization, the copay usually is the joint payment, right? So how they are using their copay cards for the refills, I think that's one of the driving factors in the data. We see that some of the age barrier actually help you to make it as a more compliant, right? So there are a demographic factor which is driving this information, and there is also payer and the provider versus pharmacy. So all this leads to the adherence along. So once you know, I think you can potentially intervene according to controllable versus uncontrollable features, how we actually get into the sensitivity part of it. Coming to the another one. So I think once you Other, I think this is a more a retrospective, but I think that can be easily converted into predictive. Can I predict whether the patient is going to drop off or not? Once you have that kind of framework ready, you can potentially use that for taking actions before, or you can actually use that as a prescriptive modeling to basically take action to ensure that they don't drop off. So basically you can use it for improving your patient programs or patient services across. So coming, the next one is, I think, the patient journey itself. So basically the stop the drop is mostly focusing on the pill or basically the drugs which you are taking, whether you are going to be on the drug or not. One of the generic framework, if you go from the predictive perspective, would be the patient journey itself. So the patient journey in their therapy, potentially they hit a lot of different things. So they have a diagnosis, then they potentially go for a treatment, followed by they meet a lot of physicians. So each of them is an action which they are taking, and each action has a lead to some sort of impact on their therapy or on their disease condition, on their current state. So in this, so basically the next, if we are able to get this information, how we can actually get that framework ready for actually predicting the next event. So that will actually help us with lot of different things. So this potentially can be used for the right targeting. So if I know, for example, which patient is going to reach cancer in next 3 months, I know my funnel which is going to reach to that level, or if I know when they are, it can help me with the right time to enter and reach the customer, and potentially it will also help me with the right messaging if I know the state in which they are going to be. So if it is a very critical versus less critical, potentially that can be used for the addressing the timing. So in the second use case, what we are trying to do is we are trying to take the sequential data which we actually get at a patient level, at a ICD 10 level codes, and try to predict a event of interest. So for example, my event of interest would be onset of cancer, for example. So can we actually use the sequential data which we are getting from the patient and predict and classify which patient is going to have an onset, for example, let's say in next 3 months. Right? So one of the information which we basically integrate with the whole thing is, so the data which potentially require, there is a, because we are trying to integrate all the diagnosis, procedure, treatment for a patient level, we are trying to integrate all the hospital claims data. So when they are going to the hospitals, what kind of treatment they are going on, what kind of drugs they are going into. So there is a pharmacy information we have to take into account. We basically use all the EMR data, which basically, or EHR data, which is the electronic health record, to basically integrate these sources of data to basically create a patient level journey. So for each patient, how they are moving from, so they, for example, a patient went for a diagnosis followed by a treatment, and then he referred by a physician to do some sort of surgery, and then he went for a drug. Then again after 3 months he come back, and then there is again some sort of diagnosis happen, and then the doctor referred him for another diagnosis lead to some sort of onset, right? So he realized that there is onset, and he changed the therapy after that. So so that's how the most of the patient journey look like. And then one of the major challenges with the patient journey is sometimes they are very, very sparse. So for example, patient comes for a diagnosis this month, and he do not come for 3 months, and then there is a data point existing for the same therapy. The other level of challenges which you actually observe is comorbidity. So there is a lot of benign event which can come into picture if you get into that level. So because if one disease can lead to another disease, and there is a combination lead to much more complexity in terms of noise which is induced into the sequence. So the other is the amount of ICD codes you have, right? So for example, for the diagnosis, if you look into, there are around 68,000 ICD codes which are present in ICD-10, which actually increased from 13,000 from the ICD-9 system. So there is so many different events which you can have, And there is so many different combinations through which you can reach to a state for any event defined event. So one of the things is how you basically restrict your funnel just to ensure you basically doing some sort of valid model. So just to give you an example, so this one of the examples which we tested is into the oncology space, basically just to see predict an event which is going to have onset in next 3 months. Can we actually get the can we use all the patient sequence information and basically have that answer in the next 3 months? And basically the steps which we follow is there are two major information which we need to capture. One is how this sequence is going to look like. So basically how actually compress the sequence into a better representation. So we basically that require embedding. Basically we build embedding on using globe, which basically convert a standard sequence representation into low manifolds dimension, which give me a much more structured form to use. Once you have that embedding basically has been fed into a bidirectional LSTM based on model. So LSTM is a recurrent neural network model which actually use a long short-term memory. And then we try to classify whether we are able to get that information out in terms and able to predict the events which is going to happen into a system. So in the process, basically there are two major things which we actually try to identify. One is can we use the